Welcome to this talk on neuromodulation. This is the way we're going to structure the talk, and the aim really is to give you an overview on neuromodulation, which doesn't only include spinal cord stimulation. So this is the guy that started it all, Norm Shealy. He, as you can see from the paper here, started publishing on neuromodulation in 1967. That's only 2 years after the gate control theory came along, and he's got a couple of websites you should go and have a look at. He's still doing a lot of work. But let's ask ourselves, what is the definition of neuromodulation? Because most people really think of neuromodulation as spinal cord stimulation, and it is, but there is more to neuromodulation than just spinal cord stimulators or stimulation. This is the INS, the International Neuromodulation Society definition of neuromodulation: technology that acts upon nerves. But then it goes on to saying that it's alteration or modulation of nerve activity by delivering electrical or pharmaceutical, and that's the key, or pharmaceutical agents directly to a target area. So that means electrical impulses in the stimulation, so neurostimulation, neuromodulation, or medication, pharmaceutical agents. So not only does it include spinal cord stimulators, but it also includes intrathecal drug delivery systems. And there is a picture of one of these implantable intrathecal pumps. The paper that you're seeing referenced is a good paper to have a look at, and it's a good overview. It's a consensus guidelines published in 2010 for the use of intrathecal systems in non-cancer pain, because intrathecal systems can also be used in cancer patients and certain cancer patients, and they can either be externally implanted or with the use of ports, or internally planted as well. Cost is a big issue, and there are a number of other things that need to be considered when using them in cancer pain. So cancer pain, non-cancer pain, and also for muscular abnormalities and spasticity, so the use of intrathecal baclofen pumps as well. So those are the three main groups of intrathecal drug delivery. But this paper concentrated on non-cancer pain, and as I mentioned, it's a consensus guidelines, and it was quite a good overview, and I recommend, if you have any interest in this, then having a look at this paper. Those are the subjects that this paper went on to discuss. They had a look at the systems themselves. They looked at the selection of patients, advantages, disadvantages. They also had a look at various comorbidities, and you'll see a list of the comorbidities that they discussed in detail, because patients that get these systems have comorbidities. That's just by definition the group of patients that they are. So important to have an idea about how to manage these patients with comorbidities. The thing that I want to remind you about from the paper, which I found pretty good, is they had an algorithm to the use of medication, because it's something we all want to know. Well, what are we going to put down there, how much, and when are we going to escalate things? And this is how they define the medication. So first line, second line, all the way to sixth line, or kind of experimental drugs that they could use down the intrathecal pump. So first line medications are opioids: morphine, hydromorphone, or zaconotide. Now, zaconotide is essentially available overseas, particularly in the USA. It's a non-opioid, non-anti-inflammatory N-type calcium channel inhibitor, and apparently it is quite useful. I haven't got experience with the use of zaconotide, but as you can see, first-line therapy for particular patients, and I think that's the neuropathic type pain. Second line is the addition of, so you could use fentanyl, you could have the morphine hydromorphone with zaconotide, morphine hydromorphone with bupivacaine or clonidine, so opioid essentially plus something else, local anesthetic. That's the main one. Third line, and again, as you move on, you're adding in additional medication. So third line could be clonidine by itself, or opioid, either hydromorph fentanyl with bupivacaine plus clonidine plus zaconotide, and so on, all the way to sixth line, where they're putting things like gabapentin, octreotide, and neostigmine, and there are a bunch of other medications or agents that just have numbers as their pharmaceutical names. So intrathecal drug delivery systems, if you're talking about neuromodulation, don't forget to mention that. This is an interesting paper, and this is a reminder that intrathecal opioid therapy is dangerous, and this is for non-cancer pain. This group had a look at 9 sentinel or 9 kind of key cases where there were deaths related to the implantation of opioid delivery systems intrathecally. And they used one of the company's registers, one of the implantable company's registers, and they had a look at a group of patients, and they found that the mortality was excessively high compared to other implantable systems. And the mortality, they couldn't define a cause for the mortality, and it might be due to the system implantation itself and the initiation of opioid therapy. Respiratory depression or respiratory arrest was associated with all the 9 deaths. And those are the numbers. They found that at 3 days the mortality was 0.088%, at 1 month 0.39 or 0.4%, and at a year the mortality was almost 4%. So let's spend some time talking about the mechanisms of spinal cord stimulation. Interesting thing is when you talk about spinal cord stimulation, there are a couple of things that are unique about it. It works for chronic neuropathic pain. It doesn't work for acute and nociceptive pain. You need to paint over the area of the pain. So when you're doing a trial, you need to get somatotopographical cover of the pain itself. It takes minutes to work, and even weeks and months to get to its full potential. Spinal cord stimulation works best for the burning and allodynic kinds of elements to the pain, and the relief lasts longer than the stimulation itself. So when patients switch it off for various reasons, or even if it needs to come out, the relief can outlast that level of stimulation or that time of stimulation. So there are some interesting aspects of spinal cord stimulation. Very briefly, just giving you an overview of a bit of the terminology and how it actually functions. There are 2 parts to the lead as per se. They're cathodes and anodes. Now the cathodes are the negatively charged, and I'm just going to basically read through this a little bit. The cathodes are the negatively charged or active electrode, and they make surrounding neurons more positive and lead to depolarization. So cathode, negative, leads to depolarization. Anodes are the positively charged, and they essentially are there to shield surrounding neurons from the effects of the cathode, and that's called the anodal effect. So anodes are about hyperpolarizing surrounding areas and really shielding things. Electrical conduction, CSF conducts the most, bone conducts the least, and that's pretty good. CSF, then long white matter, then grey matter, transverse white matter, fat, dura, and bone. It's good that bone doesn't conduct electricity very well, because that shields vital structures such as the heart from the effects of spinal cord stimulation. So there you have a stimulator in situ in the thoracic region, and that's a paddle type stimulator, so that would be surgically implanted. And just a couple of pluses and negatives to give you an idea. So you've got, say, the central cathode area, which leads to depolarization, and this is like a tripolar kind of configuration with anodes on either side, and leads to hyperpolarization, and really protecting it and focusing that electrical stimulation on the central area of the spinal cord, or the physiological midline of the spinal cord. So the mechanisms, people might ask you, how do spinal cord stimulators work? Well, we know that they're involved with stimulation of large A beta fibers, so closing the gate, and that's the classic theory of spinal cord stimulation. But there are other things going on as well, and the main ones are in green. So neurochemistry, there are changes with neurochemistry, there are changes with neurophysiology, and there are changes within the sympathetic nervous system. And the sympathetic nervous system is important because we know it has anti-anginal, anti-ischemic type effects. Now, so if there's one thing you need to remember from this slide, or 2 things, it's A beta fibers, large A beta fibers, and it's GABA. It increases the effects of GABA and the release of GABA, and that has a depressing effect or neuroinhibitory type effect. And as you can see, there are other things as well. And there are a couple of mentions of activation of supraspinal structures, switching on of ascending or descending inhibitory pathways, antidromic activation as well, which is back away from the direction of which the fiber is firing, so against the norm. So let's look at the equipment. There are three parts to stimulator systems. There's the lead, the pulse generator, and the programmer. And there you have it there. The pulse generator, the leads, and the program. And the program is something that the patient carries around, and they adjust it as they go on about their day, up, down, off, on. Some of the newer stimulators have really fancy kind of modes where they adapt to the patient's position. Right, so the programmer basically programs three aspects of the electrical impulse, and that's the amplitude in volts, the pulse width in microseconds, and that adjusts the area that they feel, the area of paresthesia, and the frequency in hertz, which is an individual preference, and some patients have different sensations that they're happy to feel, so buzzing and those kinds of things. So the indications, these are the four main indications for spinal cord stimulators. There are a lot of people doing putting stims in for a lot of indications, but these are the four classic indications. Failed back surgery syndrome with radiculopathy or with peripheral neuropathic pain. Neuropathic pain per se, and the classic one is complex regional pain syndrome. It is a peripheral neuropathic pain condition. Although, of course, complex regional pain syndrome may not per se be called a neuropathic pain condition, and it may not fit under that umbrella of neuropathic pain. But that's for another discussion. Angina, so refractory angina, is an indication for spinal cord stimulation, and peripheral limb ischemia, so critical ischemia and peripheral ischemia. Classic 4. And I direct you to quite a couple of good publications out there where you will get reference to the randomized controlled trials that have been done, and they can only do trials to a degree, of course. You can't get completely double-blinded randomized trials with spinal cord stimulators because of the actual technique of doing it and the hardware itself and ethical considerations. So I direct you to a couple of these good publications, good overviews. You'll get a number of details of the RCT, certainly from the British Pain Society's recommendations for best practice. And the National Institute for Health and Clinical Excellence, so NICE in the UK, published, that was in 2008. It's supposed to have been reviewed in 2011, but I couldn't find the actual new update. So spinal cord stimulation for chronic pain of neuropathic or ischemic origin, and those are the two main indications by NICE. And then I just wanted to give you a paper that I found in 2011 out of Pain Practice, where a group had a look at the patients that they put stimulators in and defined their indications, and there are the numbers there. So half had them implanted for CRPS, 33% had them implanted for failed back surgery syndrome, 10% peripheral neuropathy, visceral pain, 5% of which there can be a number of uses, and people are now doing them for visceral pain, and peripheral vascular disease, only a small percentage. I quite like this group of indications for spinal cord stimulators, published by the Faculty of Pain Medicine of Australia New Zealand College of Anaesthetists. Conditions likely to respond, conditions that may respond, and conditions that rarely respond. So it puts into your mind a whole other group of conditions. And the ones likely to respond are the ones we've talked about already, the classic ones: failed back, complex regional pain syndrome, refractory angina, and neuropathic pain. And then may respond, you've got peripheral vascular disease, brachial plexopathy, axial pain following surgery, so failed back surgery with axial pain. However, new techniques for stimulators now are such that they may actually get cover, so that painting over of the axial back pain with new types of stimulators. So we may be seeing more stims for axial back pain following failed back surgery. And then, of course, rarely respond with spinal cord damage. So if you haven't got a spinal cord, it doesn't work. If you haven't got some kind of transection of the spinal cord, stimulation doesn't work. And that might be because of the whole ascending, descending pathways that are involved. So contraindications are the classic contraindications that one would consider, and you always should consider absolutes and relatives. And the most important absolute one is if a patient says no. The other big ones are any kind of coagulopathy and localized infection at the site. So those are the three for anything that you do. Patient refusal, coagulopathy, particularly for neuraxial procedures, and here I've added in anything that increases surgical risk, and localized infection. The relative contraindications: systemic infection, psychological, cognitive issues, because the patient needs to be on board with these techniques. They need active patient engagement. Psychiatric issues, substance abuse, cognitive disorders, pregnancy and pacemakers and defibrillators, which we'll come to. So spinal cord stimulation, complications, and again, when you're discussing them, when you're thinking about them, they can be early complications and delayed complications. And the early complications could be due to the surgical procedure or the percutaneous electrode implantation. So those things that happen with a big needle and a strong shoulder, or if it's a surgeon with a scalpel. And then the other complications that are pretty self-explanatory. And the one I draw your attention to is lead migration, because that's one of the commonest things that happens, and it can happen early and it can happen later on. And it may be to the point that things need to be revised. That's what usually happens. I draw your attention to this paper again out of Pain Practice from 2011, looking at complications from a real group of patients. And they looked at trials and the actual implantation. Trials, lead migration, less than 1%. That was the only main complication of trials. And then the implantation, you could consider the side effects or complications into hardware related and biologically related. And the main ones, again, are hardware related, are lead migration, up to a quarter lead migration. So lead anchorage is a big thing at the moment, and it is important because you want to get that lead staying exactly where you put it. And of course, with the patients being more active, the leads could migrate, and they tend to migrate higher up you put them. So cervical leads tend to migrate compared to the lower down. Lead connection, lead failure, lead breakage, and then the biological complications, and the main ones are pain and infection. And infection is a big deal because diabetics tend to get more infections than non-diabetics, so you need to consider these things. And reducing complications is done by meticulous technique and meticulous attention to detail. They did note that there were no permanent neurological deficits or death. So spinal cord stimulation, on the whole, is a relatively safe procedure, but there are common minor complications and very rare few major complications. Now, the other things I want to remind you about is when you're talking about stimulators, you need to consider a number of things that the patient needs to be aware of. So pacemakers, stims can interfere with pacemakers and probably vice versa as well. So that is a relative contraindication and needs to be considered. Airports, well, if a patient walks through fancy airport security, they're going to set off a few alarms, so they need to have details in place, documentation, to protect them from our border security officers. Diathermy does and could interfere, so you need to consider this, particularly for the anaesthetists in us that are going to be anaesthetizing more and more of these people for non-kind of pain-related issues. So if you're using diathermy, you want to use local diathermy, so bipolar diathermy. Antibiotic prophylaxis, the British Pain Society made recommendations that these patients shouldn't receive antibiotic prophylaxis for every kind of invasive or procedure that they should have just because they've got a stimulator in. This is probably open to debate. I know what I'd want if I had hardware in myself, but that's just a personal preference. We need to follow the evidence. And then MRIs, stimulators and leads can interfere with the MRI itself, so it can cause an artifact on the images, and the MRI can interfere with the stims, and they can cause lead migration, heating up of leads, and I presume other complications as well. So be aware of these kind of unique characteristics or unique kind of situations. I just wanted to mention other indications for neuromodulation in pain, and there are now being put in peripherally, so we're stimulating peripheral nerves with stimulators. So this is not spinal cord stimulation, this is peripheral nerve stimulation, and the key one out there, and there are a number of papers coming out, are looking at occipital nerve stimulation, particularly for chronic migraine and medication overuse headaches. So a lot more to come with regards to neurostimulation and headaches. And then even peripheral nerve field stimulation, so just sticking the stimulators not subcutaneously but in this peripheral nerve field and hoping to get topographical coverage of an area of peripheral, just a peripheral area of pain. And there are some papers out there looking at chronic abdominal pain, and I know colleagues that are doing them for other things as well. So sacral pain, they're putting stims bilaterally over coccygeal areas. So there's a lot of non-evidence-based, non-evidence-guided practices that are occurring. So I call to follow the evidence. And then again, when you're talking about neuromodulation, we always think about it with regards to pain control, but neuromodulation is being used for a number of other non-pain conditions, and there's a lot of research going into neuromodulation at the moment. So movement disorders, I quite like the psychiatric disorders one. There are a lot of psychiatric disorders that they're now doing research on with regards to neuromodulation. So depression, OCD, even anorexia, strokes and brain injury, dysmotility, gastroparesis, so gastrointestinal disorders, urogenital abnormalities and colorectal disorders, so incontinence is treated with neuromodulation. Sensory deficits, retinal stimulation for blindness. There's a really fascinating things that they're doing out there, and very new and emerging things like Alzheimer's and even obstructive sleep apnea. So these are newer directions that neuromodulation is pointing into. So that brings us to the end of this introduction to neuromodulation.